I'm Dr. Lori Conway, internal medicine, 18 years in clinical practice, the last 9 of them focused specifically on care for patients over 60. And I am making this video because that committee room moment deserved a conversation that it did not get. And that conversation belongs with you, not just with us. Here is what I need you to understand before we go any further. The screening guidelines your physician follows were not written for you. They were written for populations. They were built by committees analyzing data from thousands of people and producing recommendations for a statistical average patient, a hypothetical individual who does not smoke, has 1 chronic condition, takes 2 medications, and lives in a median zip code. That patient does not exist. You exist. And the gap between the hypothetical patient the guidelines were written for and the actual person sitting in the examination chair is a gap that the system, in its 15-minute appointment structure, its liability-driven decision-making, its checklist momentum, does not have a reliable mechanism for closing. I am not here to tell you to distrust your doctor. I am here to tell you to talk to your doctor differently, to ask the question that the system rarely builds time for. Not what did the test find, but what does finding it actually change for me, at my age, in my body, with my life ahead? Those are not the same question. And after 60, the distance between them can mean the difference between a life well managed and a life derailed by a diagnosis that was never going to harm you. Today, we are going to walk through 5 medical screenings where that distance is most significant. 5 tests where the conversation you have before you agree matters as much as anything the test itself might find. Let me start with the one that sits in my own specialty's complicated territory, the intersection of internal medicine and vascular surgery, because I've watched this particular pathway go wrong enough times that I feel a professional obligation to explain it clearly. A carotid ultrasound is an imaging study of the large blood vessels running up each side of your neck, the ones that carry blood from your heart to your brain. The test is genuinely painless. You lie on a table, a technician runs a small probe along your neck for about 20 minutes, and the machine produces images showing whether there is any narrowing in those vessels. No needles, no radiation, no discomfort. From a patient's perspective, it feels like nothing. The problem is not the test. The problem is the road the test puts you on. When that ultrasound shows narrowing, and in older adults, some degree of narrowing is remarkably common. The clinical pathway has its own gravity. The system orients toward intervention, a referral to a vascular surgeon, a discussion of a procedure to clear or support the narrowed section. The logic feels intuitive. Narrow vessel means reduced blood flow to the brain, means stroke risk, means fix the vessel. That logic is sound for one specific group of patients, people who have already experienced neurological symptoms. A sudden episode of weakness on one side of the body, a brief period where speech became difficult, temporary vision disturbance in one eye. For patients who have had those experiences, carotid intervention has meaningful, documented benefit. I support it without reservation for that population. But here is where the clinical picture changes dramatically. For patients with no symptoms whatsoever, who feel completely well, came in for a routine visit, have never had a neurological episode, the data tells a profoundly different story. Large, rigorous clinical trials have examined the risk comparison directly. The annual stroke risk from an asymptomatic narrowed carotid artery versus the stroke risk from the surgical procedure designed to fix it. And what those trials found is that for many asymptomatic patients, those 2 numbers are not far apart. The operation you undergo to prevent a future stroke carries a procedural stroke risk that for someone with no current symptoms can be similar in magnitude to the natural risk of leaving the narrowing medically managed and monitored. In medicine, we call this the risk-benefit inflection point. And in asymptomatic carotid disease, for older patients, that inflection point is not where most patients assume it is. What the evidence supports for asymptomatic narrowing is optimized medical management, blood pressure control, statin therapy, antiplatelet medication, lifestyle modification, combined with monitoring. That approach in multiple trials has performed at least as well as procedural intervention for patients without symptoms and without carrying the procedural risk. So before you agree to a carotid ultrasound, and certainly before you agree to anything that follows from one, ask your physician this: I have no neurological symptoms. What does the trial evidence show about intervention versus medical management for someone in my situation? And I want numbers, not general reassurance, not that we caught it early, actual comparative risk numbers. A physician who has read the literature will engage with that question. The answer may surprise you. Stress testing is a central part of my clinical world, so I want to be careful here about the distinction between appropriate and routine, because those two words in cardiology point in very different directions. A cardiac stress test, whether performed through physical exercise on a treadmill or through a chemical agent that simulates exercise for patients who cannot walk strenuously, monitors your heart's electrical activity and blood flow under demand. For patients who are experiencing chest pressure, unexplained breathlessness, or other cardiac symptoms, the information it provides is genuinely valuable. I order stress tests regularly for that population, and I believe in the tool. The issue arises when stress testing is used as a general screening instrument for older adults who feel entirely well. No chest discomfort, no breathlessness climbing stairs, no cardiac symptoms of any kind. Came in for a physical. Doctor wants to check the heart. In that context, asymptomatic older patients, cardiac stress testing has a significant and often underappreciated problem: a substantially elevated false positive rate. The test, reading the cardiac patterns of an older heart, more frequently flags something that appears to indicate reduced blood flow when the heart is actually functioning normally. Age changes the electrical signature of the heart in ways that increase the likelihood of a technically abnormal result in a person with no actual cardiac disease. But an abnormal stress test result does not sit quietly in a chart. It generates momentum. The next step is almost invariably cardiac catheterization, an angiogram. A catheter inserted through an artery, typically in the wrist or groin, threaded up to examine the coronary arteries directly. Angiography provides detailed information, and in the right clinical context, it is the right tool. But it carries its own risk portfolio: bleeding at the insertion site, kidney stress from the contrast material used to visualize the vessels, and a real procedural risk of stroke, risks that increase meaningfully with age. And here is the clinical reality that two landmark trials, the COURAGE trial and the ischemia trial, established, with evidence substantial enough that it changed cardiology practice guidelines. For patients with stable coronary artery disease and no acute cardiac event, stenting or bypass surgery produced no improvement in heart attack rates or survival compared to optimized medical therapy alone. The outcomes were statistically equivalent. The patients who received the procedures did not live longer or have fewer heart attacks than the patients who received the right medications and monitoring. What this means in practical terms: a routine stress test in an asymptomatic older adult can trigger a catheterization that reveals narrowing that generates a stent procedure that carries procedural risk. And that stent may add nothing to that patient's life expectancy or quality that the right medication regimen would not have provided without the procedural risk. The most powerful tools for protecting your cardiovascular health after 60 run through blood pressure control, cholesterol management, smoking cessation, and physical activity calibrated to your capacity. These are not consolation prizes for people who can't have procedures. They are the interventions the evidence supports. Before agreeing to a routine stress test, ask, if this test comes back with an abnormal result and I have no cardiac symptoms, does the clinical evidence support proceeding to intervention for someone my age? The answer to that question should be part of your decision before the test, not a surprise you encounter afterward. I want to be unambiguous about something before we discuss this one. Colonoscopy as a screening tool in your 50s and early 60s has genuine, well-documented benefit. The evidence for colorectal cancer screening in that age range is real. I would not dismiss it, and I am not suggesting you should. What I am telling you is that after 75, the calculus changes in ways that most patients are never shown. And the failure to show patients that calculus is a significant gap in how medicine communicates with older adults. Here is the biological fact at the center of this. Colorectal cancer is, by the standards of most malignancies, a slow-moving disease. The progression from a small precancerous polyp to a clinically dangerous cancer typically requires somewhere between 10 and 15 years. Apply that timeline honestly to a 76-year-old patient. A polyp identified at that appointment has a realistic window of harm somewhere around age 86 to 91, at which point, with considerable probability, other health considerations will be the dominant clinical reality. The question medicine should be asking for that patient is not whether we found something. It is whether what we found would ever have caused this person harm within their realistic remaining years. For many patients after 75, the honest, evidence-based answer is probably not. But here is what troubles me most about the automatic extension of colonoscopy screening into later decades. The procedure is not without meaningful risk in older bodies, and those risks are consistently underweighted in the conversations patients receive. The preparation alone, the bowel cleansing required before the procedure, causes significant fluid and electrolyte shifts. In a 25-year-old body, that is an inconvenience. In a 78-year-old body, the kidneys manage fluid shifts differently, the cardiovascular system compensates differently, and the risks of preparation-related complications are qualitatively higher. I have seen patients require emergency care, not from the colonoscopy itself, but from the preparation process. Then there is sedation. Older adults metabolize anesthetic agents more slowly. Post-sedation cognitive effects, confusion, memory fog, disorientation, are more frequent in this population and occasionally more lasting. The procedure itself carries a perforation risk that, while small in absolute terms, is highly consequential in a patient whose surgical repair options carry significant mortality risk at advanced age. Stack those procedural risks against a polyp that mathematical biology suggests may never have caused a single symptom. That is the calculation your physician should be walking through with you before scheduling the procedure. Not afterward, not during the prep, but before. The American Cancer Society's guidance reflects this explicitly. Screening decisions after 75 should be individualized based on health status, life expectancy, and personal values. The word individualized is carrying enormous weight in that sentence. It means the conversation has to happen first, and it means you have to be in that conversation. This section requires the most careful handling because it lives in territory that carries genuine emotional weight. And that emotional weight can make clear thinking about evidence genuinely difficult. I want to be precise and honest, which means I need to start with the distinction that medicine has been slow to communicate clearly to patients. Not all cancers behave the same way. Not even all cancers of the same type, in the same organ, detected at the same stage, behave the same way. Some grow aggressively, spread early, and genuinely threaten life within years of development. Others grow so slowly, remain so locally confined, that a patient who lives with them for decades may never experience a single symptom attributable to that cancer. They may ultimately die of something entirely unrelated, the cancer present but never dominant. This distinction between clinically significant disease and what pathologists sometimes call indolent disease is the central issue in cancer screening for older adults. Because our screening tools, PSA blood tests and mammography, detect the abnormality, they cannot, at the point of detection, reliably tell you which category the abnormality belongs to. And when the abnormality is found, the treatment pathway does not pause to make that determination before it begins moving. Both categories of findings enter the same clinical machinery: surgery, radiation, hormone therapy, each carrying real, lasting physical consequences. Fatigue that persists for months, urinary incontinence, bone density reduction, effects on daily functioning that can be significant and durable, for a finding that in some patients would never have caused a single day of illness. The U.S. Preventive Services Task Force has taken a clear position on PSA screening for men 70 and older. It recommends against it. Not because prostate cancer cannot be serious, it can be, but because the mathematical reality for this age group is that the harm from detecting and treating slow-growing disease consistently outweighs the benefit from catching the aggressive cases that would genuinely benefit from early intervention. The mammography conversation after 70 is more actively debated, with legitimate disagreement within the medical community about where the evidence points. What is not debated is that the conversation should happen, and that it should include what treatment would realistically look like if something were found, what that treatment's side effect profile means for your specific life and priorities, and what you value most in the years ahead. I am not telling you to decline cancer screening categorically. I am telling you that the conversation about what happens after a finding is discovered must be part of your decision before you agree to the screening. Not discovered in the oncologist's office after a biopsy confirms something. Before, when you still have the full picture and the full choice. A DEXA scan, the standard bone density measurement, is one of the most physically benign tests in medicine. Minimal radiation exposure, approximately 10 minutes, no discomfort, no preparation. As a source of information, I have no objection to it. My concern is with what that information reliably triggers, and whether what it triggers is always the most effective response to the underlying problem. When DEXA returns a score indicating low bone density in a patient in their late 70s or 80s, the clinical response is almost reflexively a prescription for bisphosphonate medication. These are drugs, alendronate, risedronate, and others, that work by slowing the natural process by which bone tissue is broken down and rebuilt. The intention is sound. Denser bone breaks less easily. But in patients over 80, the timeline for bisphosphonate therapy to meaningfully reduce fracture risk runs 3 to 5 years of consistent use. The absolute benefit, meaning actual fractures prevented per 100 patients treated, is real but modest, typically in the range of 2 to 3 fractures prevented across several years of treatment in a population of 100 patients. That is a genuine benefit, but it needs to be weighed against what the medication costs in side effects for the individual taking it. Bisphosphonates can cause significant gastrointestinal complications. Esophageal irritation and ulceration are documented and not uncommon, particularly in older patients who may already have digestive sensitivity. And there is a counterintuitive risk called atypical femoral fracture, where prolonged suppression of the bone remodeling cycle causes the thigh bone itself to break in an unusual pattern under ordinary mechanical stress. A medication prescribed to prevent fracture can contribute to a different kind of fracture with prolonged use. What the evidence most strongly supports for fracture prevention in this age group is not a prescription. It is a program. Muscle strength and balance training, which address the primary mechanism of most osteoporotic fractures, a fall. A thorough review of every medication the patient takes for anything that causes dizziness or affects balance, because falls are the pathway, and falls are preventable through pharmaceutical adjustment. Adequate protein intake, vitamin D if blood levels indicate deficiency, modifications to the home environment, lighting, floor surfaces, grab bars that reduce fall risk concretely. These interventions address the actual causal chain between a vulnerable body and a fractured hip. None of them require a prescription. None carry the bisphosphonate side effect profile. And their combined effect on fall prevention is supported by strong evidence. If your physician recommends a DEXA scan, by all means discuss it, but push the conversation one step further. What fall prevention program accompanies any medication decision? That question is at minimum as important as the prescription itself, and it is asked far less often. I have spent significant time describing what to question. I want to be equally clear about what to embrace, because the argument I am making is not that medicine after 60 should be avoided or minimized. It is that it should be calibrated. Blood pressure management is among the most powerful interventions available to anyone in this age group. Uncontrolled hypertension predicts stroke, heart failure, and cognitive decline in older adults more reliably than almost any other measurable factor. If you have one thing to manage actively, make it that. Cholesterol management, particularly for anyone with existing cardiovascular disease, deserves a regular, honest conversation with your physician, including a periodic reassessment of whether a medication started years ago still makes sense for where you are now. Vision and hearing deserve far more clinical attention than they typically receive. Uncorrected vision is a direct and quantifiable fall risk. Untreated hearing loss is connected in multiple well-designed longitudinal studies to meaningfully accelerated cognitive decline. These are not quality of life peripherals. They are brain health issues, and they are treatable. Vaccination remains the highest benefit to risk medicine available to anyone over 60. Annual influenza protection, pneumococcal coverage, shingles prevention, updated respiratory virus protection. The evidence supporting these in older adults is overwhelming and consistent. And then medication review. The quiet accumulation of prescriptions across years of appointments with different specialists, each treating a single system in isolation, creates interaction risk and side effect stacking that is genuinely underappreciated in clinical practice. A drug that was clinically appropriate for you at 62 may be actively working against you at 79. Ask your physician to justify every item on your medication list annually with your current health status as the reference point. Everything in this video only protects you if you can bring it into the examination room. And I know that room has its own dynamics. Time pressure that is real, a knowledge gradient that is real, and a worry about appearing difficult or uncooperative that I hear from patients constantly. So here are 4 questions you can write on paper and read directly from. No memorization required. First, can you explain what this test is looking for and what the clinical pathway would be if it finds something? That moves the conversation from the present, the test, into the future, the consequences, which is where your decision actually lives. Second, are there specific risks associated with this particular screening for someone my age with my health history? Third, if we chose to monitor this rather than act immediately, what would that look like? Active surveillance is legitimate evidence-based medicine. It is not passivity. It is not giving up. It is a clinical choice. Fourth, is the research behind this guideline based on populations that specifically included people over 70? You may be surprised by how often the honest answer is that it was not. A physician who has engaged seriously with the current literature will engage seriously with these questions. They may reach different conclusions than I have in this video, and their specific knowledge of your history may justify that. But they should engage with evidence, not deflect with reassurance. 18 years of internal medicine, thousands of patient appointments, and the cases that stay with me most vividly are not the emergencies or the complex diagnostic puzzles. They are the quiet ones, the patients who arrived at a routine appointment feeling well, with no symptoms, no alarm, no reason to anticipate that the day would be anything other than ordinary, and who left carrying a diagnosis that changed the entire shape of their life, not because the finding was dangerous to them specifically, but because the system treated it as dangerous, without pausing to ask whether it was. I have watched active, independent people become patients, not because their body failed them, because a number on a report gave everyone in the clinical system permission to act. And once that permission exists, the machinery is very difficult to stop. Each step triggers the next. Each specialist hands off to another. The momentum has its own gravity. This video is about the moment before that momentum begins. The moment when a question could be asked and still has the power to change what follows. The moment when you still have complete information and complete choice. After 60, your relationship with healthcare should become more deliberate, not less, more considered, not more automatic. Every referral, every screening, every prescription deserves a real conversation about whether it is designed to serve your life, your specific life, at your specific age, with your specific values, or whether it is serving the protocol. Those are not always the same thing. Trust in medicine is not the same as unconditional compliance with medicine. Informed participation is not difficulty. It is the most responsible thing you can do for yourself inside a system that was not designed with your individual situation at its center. The 5 conversations worth having before you say yes. Carotid artery ultrasound without neurological symptoms, where procedural risk can rival the natural risk you're trying to prevent. Ask for specific numbers. Routine cardiac stress testing without cardiac symptoms, where major trials show medication management achieves equivalent outcomes. Ask what happens if the test flags something. Colonoscopy after 75, where the biology of slow-growing disease and the real risks of preparation and sedation deserve honest weight before you agree. Cancer screening through PSA and mammography, where the treatment pathway should be part of the screening conversation, not a surprise discovered afterward. And bone density scanning, followed automatically by medication, where the evidence for fall prevention programs is at least as strong as the evidence for pharmaceutical intervention. None of this is a reason to avoid your physician. It is every reason to arrive prepared. Write 2 questions before your next appointment. Read them out loud from the paper if that is easier. Notice what happens in the room when you do. Because that moment, when you ask and expect a real, specific answer, is the moment your healthcare stops being something done to you and starts being something you are genuinely part of. I'm Dr. Lori Conway. Ask the question. Read it from the paper if you need to. The question is the most important thing you bring into that room.